Okay.
Oh, let me turn off. Okay. Welcome back. Good evening, everybody. Welcome to another episode of Mondays with Maishi. Tonight, from Lakewood, New Jersey, I am here with Dr. William Miller, or Bill Miller.
Bill Miller, yes.
Also known as Bill, right? The topic of tonight's discussion, of course, is the process of motivational interviewing. In case you're wondering why that's the topic of tonight's discussion, it's because Bill Miller is the founder or co-founder of Motivational Interviewing. Now, before we get into motivational interviewing, just want to welcome everybody back, those who are on live and those who are going to watch this recording afterwards. Nice to see familiar faces and, of course, some new faces. After the show, I'd be happy to say hello to anybody who wants to give me a wave or a shout out after the show is over. I'll stay on an extra couple of minutes. Bill, I really appreciate that you took the time to join us and the mental health community, because your contribution is a great contribution. It's a contribution of motivational interviewing. And
thank you. That's my home community, mental health.
Yeah. That's it. And I'd like you to just be able to tell everybody who you are, what your background is, where you've served your time in the mental health field, if you call it that, and then we'll jump right into it.
Well, I've been in clinical psychology 50 years now. And most of that I've spent at the University of New Mexico. I came here in 1976 and retired 31 years later from my first job. So this is where I've had a wonderful career with colleagues just researching how to help people change. And one of the products of that is motivational interviewing.
Okay. Now, somehow motivational interviewing was born, and I'd like to understand a little bit where it was born from. But before that, I think one of the things I'm curious is, I learned about motivational interviewing. I was in graduate school about a dozen years ago, and we learned motivational interviewing as a modality to treat addictions. We actually learned it in our addictions class. You know, from all the things out there, why do you think that motivational interviewing made it? Like, what about it made it?
I ask myself that all the time. I mean, I know of 61 languages where this is being taught and practiced now, clear around the world. That seems to even cross cultures well. And it's not that you have to persuade people to do this. When they begin to hear it and learn about it, it's like people recognize it or are attracted to it and want to learn more about it. So there's just something fundamental about human nature here that makes sense to people and that attracts people. And now we have a huge evidence base as well. There are more than 1,700 controlled trials involving motivational interviewing in the literature now.
Wow. Okay, so I guess it's progressed since 12 years ago.
Amazingly, yeah.
Okay, so how was motivational interviewing born?
Well, that's a good story. I went on my first sabbatical leave to Norway in 1982, hired to come in and talk about behavioral treatment of alcohol problems. And I was at an alcoholism hospital on a fjord outside of Bergen, beautiful setting. And they gave me a lovely office in the corner looking out into the fjord. And the director of the clinic said, "Would you be willing to meet with our psychologists? Most of them are pretty fresh out of school, and just have discussions, just chat and see what happens." I said, "Sure, I can do that." And it turned out to be one of the most important parts of that sabbatical leave, because I was teaching them both Carl Rogers, the person-centered way of being with people, and behavioral treatment methods. But what they wanted to do was have me not just tell them about it, but show them how I would work with people. And so they would role play patients they were seeing, some of their more difficult patients in English, and essentially say, you know, "Okay, smart guy, what would you do with this?" And we would role play it. And they did in the process something my American students never did or rarely did, which was interrupt me. So I would be demonstrating what I might do with a patient. And someone would say, no, stop just a minute. Now, what are you thinking at this point? Or you just asked a question, but why did you ask that question? You could have asked many questions. Why that question? You just reflected something that the client said, as you've been teaching us to do. But how did you know what to reflect? I mean, why did you decide to reflect that particular content and not something else? And they caused me to verbalize some decision rules that I was using and not conscious of. And we began to put a framework around it. The essence of it was to arrange the conversation in a way that it is the client who makes the arguments for change rather than I myself. Never pushing back against what might be perceived as resistance, but interested in understanding the person's own perspective on things and asking them about their own motivations for change, which was almost the opposite of what was being done in the addiction field in the 1980s, which was very authoritarian, prescriptive kind of treatment, often with a tone of sit down, shut up, and listen. You don't know anything. We're going to tell you what you need to know. This was more, tell me what you're experiencing and what's happening and how are you thinking about your life? How does drinking fit into it? What are you thinking that you might change about that, if anything, and why? And so we together put together a set of kind of decision rules for use in counseling with people with addictions at the time. And I wrote that up in a paper and we gave it the name Motivational Interviewing. And I published it in a British journal I had never read. And I figured that was the last I would hear of it. And instead it took over my life because it took off not just in addiction treatment, but quickly in healthcare as well. And then in many other fields, in corrections, in social work, in dentistry, in leadership. And it turns out that ambivalence, which kind of lies at the heart of this, is a universal human phenomenon, a normal human experience. And this is one way of working with people who are ambivalent about change that is the opposite of telling them what's wrong with them and what to do. And that just seems to make sense to people all around the world. And so there's this incredibly large research base now, and we've learned a lot in the subsequent 40 years about what this is, how to do it, how to teach it, how to learn it, why it works. And it's just been a fascinating journey.
Wow, that is a great story. I think some of us wish that on ourselves too. That we write an article and that makes such a profound impact that we can change the world.
And I love it because they evoked it from me. And motivational is all about evoking
isn't
from
that
people
great?
their own. Yeah. That's just this lovely synchronicity there.
Yeah. So it sounds like you kind of said in passing that you named the article Motivational Interviewing, but I'm sure there was some thought that went into that. Can you tell me about motivational and interviewing? Is it that you're interviewing the client to somehow find or detect where the motivation is? Is that the idea behind it?
Yeah, well, certainly it's about motivation and the client's own motivation. And interviewing seemed like a good word in English because it's kind of power neutral. It doesn't tell you per se who has the power in this relationship. So the interviewer might be an employer interviewing potential employees to decide who to hire. So in that case, the power is in the hands of the interviewer. But the interviewer might be a college student talking to a visiting professor.
I see. So you didn't write the article for the context of psychotherapy or addictions or addiction treatment.
Well, I was certainly. That's the world in which I was living at the time. But it quickly escaped the realm of psychotherapy and became a way of working with people, a way of being with people in primary care, in diabetes education, in management, in preventive dentistry, and all sorts of other domains that I had never even envisioned this being applied in. Yeah.
So it sounds like there's a core principle in I guess it's the communication between the two parties. Let's just call them the therapist and the client or the patient.
Mhm.
Is that where the energy here is?
Very much. And it can be parent and child. I mean, it can be all kinds of relationships. So
Okay.
it's
I was
not
going to
just
ask you if
professional
this,
helpers.
yeah, no, because I was going to ask you later on in the show if this is something that the layperson can apply as well and has nothing to do with a modality of therapy per se, but more a modality of communication. So can you tell us a little bit, what's the core principle of motivational interviewing and how does it, let's just call it engender or help the patient to identify their motivation? What are we doing?
We started out talking about principles in our first and second edition, and backed away from that in the third edition because it's too easy to have these disembodied abstract principles and think you understand what's going on. So we're now talking about 4 processes of motivational interviewing. One of them is engaging, just developing a trusting working relationship together, common to all kinds of psychotherapy. Then developing a clear focus. Where are we going? What are we moving towards? So developing clear goals that are shared goals with the client. So you're not just talking about whatever happened to come up that week, but you know where you're going and you have a plan for getting there, which is also one of the characteristics of more effective therapists. You know where you're headed. You have a way of organized way of getting there. Then evoking is the third process, and that's the one that is fairly unique to motivational interviewing. And it has to do with arranging the conversation in a way that asks people to tell you why they would want to make this change, how they would go about doing it, what are good reasons for doing it. So essentially helping them talk themselves into change. It's having them voice the pro-change side of their own ambivalence. Most people who come to see therapists, and certainly most people walking into addiction treatment, are ambivalent about it. There are things they like about the way they're living their life, and they also know this isn't the smartest thing in the world to be doing. And so both arguments are inside of them. And if you argue with people, if you tell people, here's what's wrong with you, you're an alcoholic, this is what you need to do, you automatically evoke from them the other side of their own ambivalence, which is, no, it's not that bad. I don't think I need to do that. And who is the person going to believe? They're going to believe me, or they're going to believe what they hear themselves say. So it's almost exactly the wrong way to approach trying to facilitate change, to be telling people what to do. Instead, this is evoking from them their own what we call change talk. Right? And then that evolves into planning, into coming up with a specific way of going about it, which is also evoking. So we don't start prescribing at that point, but it's just together figuring out what's the best way, given what you know about yourself and the way you live your life, to get this done. How does it make sense for you? So your expertise is involved as a professional, but the other important expertise is the client's own expertise, because they know more about themselves than anybody else does. And if what you're trying to do is to help them change behavior or change lifestyle, you've got to have their expertise and collaborate with that for it to work.
Okay, so is planning the 4th stage?
Yes, planning is the 4th process. Yeah, they're not linear stages, really. I mean, they're very iterative. We early on, we're talking more about stages of motivational interviewing, and I think that was misleading. So it's not really linear. In a sense, it is. I mean, you engage first, and you need to know where you're going before you can start evoking change talk, because you have to have a clear goal to be moving toward. And you don't usually start planning before you've done the rest of that work, although many treatment programs say you have to have a treatment plan at the end of the first session. Well, that kind of skips over a lot of important material. But given that kind of
treatment plan, that makes the treatment plan the therapist's treatment plan, and not
that's right. That's right. It's just prescriptive. You can run it off of a copy machine, in a way, and some programs do. Yeah.
Copy and paste.
Yeah.
Now in motivational interviewing, is there any time or energy spent on what you labeled or you termed the other side. So we spend a lot of
Yes.
time evoking the pro-social behavior. What about evoking or exploring or respecting the maladaptive behavior?
We don't go looking for it. And usually clients give you plenty of it. And so at the beginning, particularly in addiction treatment, at the beginning, you're hearing a lot of defensiveness, or the person sense that it isn't really that serious a problem and so forth. And we want clients to know that we hear that and we understand it. And so early in treatment, you'll hear a lot of reflection of the opposite side, which we call sustained talk, just to form that bond and say, I get you, I'm going to hear what you're saying.
Mm.
And at some point, it begins to shift and you begin to differentially or preferentially ask about and reflect and affirm and summarize the person's own change talk. Not something you're inserting, but their own material. And that seems to be a lot of the electricity in this. But if a client raises objections again, we don't ignore them. We listen to them, we reflect them, we make sure we understand them. But you're always looking for the change talk.
Mm.
So it's common to hear change talk and sustained talk together, even in the same sentence.
That's the ambivalence.
That's normal ambivalence, sure.
Mhm.
But it's listening for and paying particular attention to the change talk in there, which is what people don't do on their own normally. When you're ambivalent about something, you think of a reason why you should change, and then you think of a reason why you don't want to change, and then you stop thinking about it because it's kind of unpleasant.
Right.
And motivational interviewing helps people stay in the considering change mode, their own material, and keep going with it in as much of a straight line as you can, rather than going around in circles. There is this thing called decisional balance, which somehow got confused with motivational interviewing and also is sometimes prescribed as a way of helping people change, which is asking about all the reasons for change and all the reasons not to change. If you do that, the expected outcome is ambivalence. And in fact, the literature says that doing that with people who are ambivalent actually undermines their motivation for change. They're less likely to change than if you didn't do that. So we don't go mining for sustained talk. We can go searching for it. We're not interested in hearing every last reason why the person loves smoking and doesn't want to stop. We'll listen to what the person raises, of course, but we're particularly interested in the other side of their ambivalence and hearing that and having them talk about that. And the extent to which they do during a session predicts whether change is going to happen or not. The balance between change talk and sustained talk is a pretty good predictor of whether the change is actually going to happen. And you, the therapist, have a lot of influence over that balance.
Okay. I have a question on that. But before that, I just want to remind everybody, for those of you who'd like to comment or question, Bill's happy to take your questions or comments, but please use the raise your hand button tab on the bottom right of the screen. And this way we'll see that you raise your hand and I'll call on you when I have a chance. So please feel free to use the raise your hand tab.
Something else you can do is have people put things in chat too. And as you see those coming out, you can frame questions.
Yeah. Okay, so here's a question that I have on any intervention that focuses on the motivation of the client. The question I have is, if we spend most of the time, or we only spend energy and time on the client's assertion that they really want to change, are we neglecting the other side that really wants to stay the same? So if the client says, I really want to stop smoking, or I really want to stop drinking, well, tell me some of the reasons that you might want to stop. What are some of the benefits it might do for you? How might it help you? What are some of the impediments of drinking, et cetera, et cetera. So the client knows that he's there to see the therapist because the therapist is the one who is going to help him change and improve his behaviors.
Mm-hmm.
But what about the fact that drinking really helps me? It makes me feel calmer. It makes me soothe my anxiety and my shame, and all the other benefits that what seems to be maladaptive behavior is actually helping me with. Am I in denial if I only discuss with the therapist my motivation and my pro-social behaviors?
Well, it's not likely to happen because people spontaneously raise both sides with you. I mean, when people are ambivalent, they talk about both sides. But there is a place for exploring that, which is in the planning process. So when you have enough motivation, when it seems clear the person wants to move forward and is more struggling with how, that's a time when you can begin to explore what will be the obstacles to that. What have you been getting out of smoking or drinking, or what's it been doing for you that's good? You don't ask that back while the person's trying to resolve their ambivalence about it. But what happens when people have resolved that ambivalence is now if you do a decisional balance, what they do is justify the decision they've made, the change. So it's much safer, I think, in the planning process to begin to raise those questions.
I see.
And begin to explore the obstacles. And we're not ignoring that at all. But it's timing, really. Kind of where do you do that? And we find it's most useful to raise that if it hasn't come up, and usually it has before during the planning process.
So in other words, in being realistic in the planning, we're now planning what some of the behavioral changes are going to be. And in the planning process, we say, wait a minute, it's very nice. You're painting a rosy picture of how you're going to change the behaviors. But what happens when a trigger X occurs and you feel like you need to go back to drinking? But in the earlier stages of creating goals or evoking, at that point, you're going to only want to focus on the pro-social behaviors.
Or primarily on those. And the client guides you. I mean, if you're doing it wrong, the client will tell you. If you're ignoring really significant reluctance the person has about it, they'll keep raising it and telling you about it, and essentially saying you need to pay more attention to this. It's because the client is the primary guide. The way you learn this is paying careful attention to how your client is responding to you.
Okay. Bill, you mentioned 4 stages: the engagement, the clear goals, creating clear goals, evoking, and planning. What specifically is there something specific in the engagement stage in motivational interviewing, or is it global, or what is it?
Yeah, let me clarify again. These are not stages, but processes. So the engaging skills are predominantly Carl Rogers. I mean, good listening, affirming of strengths, joining with the person, the very kinds of things that have been taught for more than 50 years in person-centered psychotherapy. But you don't stop using those. They continue all the way through motivational interviewing. Right? Then you begin to add on to that a focus to get clear about where you want to go. And sometimes people need help with that. Sometimes they come through the door with that. Say, here's what I want. And you don't then lose the focus either. You keep that focus through the remainder of the process. And then evoking, listening carefully to the person's own processes. And that begins to help move toward the focus or the goal. But you don't put that down either, because as you get into planning, you're still evoking from the person how they want to go about it. So it's more like 4 stairs, each one a foundation for the next one. And you move back and forth flexibly among them. So it's not a lockstep linear stage process so much as knowing where you are with these processes at the moment. And sometimes you have to go back. You step in it and you have to go back and evoke and engage again. You've done something to shake the therapeutic alliance. Sometimes you need to go back and reconsider the focus. It seems like maybe what we really should be working on is something else. So there's flexible movement among these processes. And that's why we don't call them stages so much.
Is there a reason that motivational interviewing is more synonymous with addictions than, I'm just thinking, why can't this be used with so many other psychopathologies, if we can call them that? One of the things that I find I struggle the most with is procrastination. with clients
Mhm.
who procrastinate or who experiential avoidance, procrastination. I find that to be one of the most challenging, um, uh, if we can call psychopathologies to target and to move along. Is this something that could be used with procrastination? I'd love to use this with procrastination.
Well, it turns out motivational living now is being used far more in other fields than in addiction. It's still very present in addiction programs, but it's in healthcare. And if you think about being diagnosed with diabetes, very common diagnosis these days, people are now being asked to, if they want to be healthy, make a lot of changes in their behavior and lifestyle. It's kind of an overwhelming list of them even. And most people with diabetes don't make those changes. They know they should. They have good reasons for doing it. They also have some reasons for being comfortable with the way they've been living their life. And you need to help them work that through for them to do what they need to do to be healthy with diabetes. So ambivalence is just human nature, and working through it just cuts all across the helping professions. Significant in teaching also, as a matter of fact. So this has been applied in more and more areas. The book that just came out last week is called On Second Thought. It's about ambivalence, and procrastination is a piece in that book as well. Because often what's going on with procrastination is unresolved ambivalence, and helping the person to work that through and decide the way they want to move is a way out of the forest.
So people love when we do role plays or demos. Would you role play with me on using MI for something like procrastination?
Sure. Yeah.
Okay. Let's jump right
in. No problem. So that's something that you want to work on. This
is on behalf of a client, not on myself, but I can play a client.
I'd rather talk about something that you're thinking about changing, because it tends to work better than role plays. I can do either one, but people learn more from what we call real play, where someone's talking about themselves, than when they're trying to imagine being someone else and portray them. One thing I say is there are no clients as difficult as those role played by therapists. So either way, if you're willing, I'm happy to.
Okay, I would take something. Yeah, I'll take something. Something that's fairly, I guess, innocuous.
Yes.
One of the things that I struggle with is preparation. So anytime I have to do any kind of presentation or anything that I have to take care of, I only can prepare almost like spontaneously at moments notice or moments before. Even if I know a month before that I have to take care of it, I can't seem to pull it together until it usually comes out pretty good, but I can't pull it together till a couple of moments before. The disadvantage of it is that sometimes if I need materials or other resources, I don't have enough time to pull it together. But for some reason, I find myself not getting to it till right before.
But for the most part, that's been working pretty well for you. Just coming in on the spot, knowing what to do and doing it is your normal style.
Yeah, it does. But there are times where I wish I could be better prepared. And that if I were to be better prepared, the entire presentation would be different.
How would that be better?
Well, there's times that I might be able to bring in props or other kinds of resources that just, knowledge-based or information that I could have prepared beforehand.
So it's more that having the time, even a little bit of time, to draw in other research or props or materials or whatever that you could use creatively in what you're doing. And that feels to you like that might make for better presentations.
Yes.
What else? Are there other pieces of because you're talking about taking some time really to devote to preparation. Are there other reasons why that's something that you would like to do?
I could think that maybe for my own personal development, it may be more disciplined. It may cultivate more discipline within me if I can know that when I have a project, it would be helpful for me to or I would be able to prepare beforehand.
And that kind of discipline sounds appealing to you. That's something that you'd like to have more of.
Yes.
Yeah. So could be good for you personally, professionally as well, in addition to making some better presentations and having some other materials at hand that you might not have thought of before.
Mm-hmm. Mm-hmm. I also think another thing is it would probably make me less anxious before the presentation. For some reason, when I present something, even if it's, it's a class to students, where I know the material because I'm teaching students and I'm the professional, but if I were to prepare beforehand, I think I'd be calmer going in. When I go in, I don't know what's going to come off the cuff.
Yeah. Well, I wondered about that. In fact, if there was that just anxiety component of it too, that I might just feel more settled and more peaceful going into a class, going into a presentation, if I've thought it through a little more, and not writing it down out or whatever, but just having considered what are the possibilities here.
Right. Wouldn't even necessarily take that much preparation. True.
Now, if you did decide you wanted to do that, and you have a class coming up or a presentation coming up, how would it be best for you to take a little more time to prepare? What would it take for you to do that?
Well, first it would take I would have to get myself to do it, which would be to dedicate the time.
Yeah,
which
taking the time.
Which itself I tend to avoid, to commit to a time to do it.
So that would be one piece of it,
Yeah.
of saying, I know I have this class or presentation on that date, and so on this date, I should be taking some time to prepare. And that's a departure from the way you usually have done things.
Yes, that would be a change from the way I usually do it. Although I do tell that to myself, but I don't get much further than that.
So it would take more than putting it in the calendar.
Yeah.
Yeah. What more would it take? How would you do that in order to succeed? How could you make that happen?
I think that's where it gets complicated because then I come up with 100 other things to do to run away from doing this.
It's unpleasant enough that you look for anything else to do rather than prepare.
Yes.
Yeah. So that's a significant obstacle. I mean, that kind of gets in the way.
Mm-hmm.
You would need a way of keeping the focus, saying, maybe a specific length of time, I don't know, but just the thought of preparing forever and ever, of course, is awful, but is 15 minutes sound possible? I don't know how you work, but
yeah,
you know
well, yes, it would probably, in many cases even less, and it's not the preparation itself that's difficult. It's getting into the preparation. In other words, getting started. Yeah.
Okay.
If I'm in the preparation stage, it's great. I can prepare, I can think, I can let my mind go, I can find the resources, but it's getting to the preparation that I avoid.
So once the engine turns over, it's okay.
Yes.
It's that starter. Huh? Yeah. Okay. Well, this could go on, but that's a reasonable demonstration of this way of having a conversation about change.
Well, I see the Rogers pieces in it where there's a lot of reflection, a lot of demonstration that we're talking the same language and you're understanding my perspective, and I see that.
And where it differs from Rogers, I think Rogers actually did this too, but where it consciously differs from Rogers is the strategic direction of it, of deciding what am I asking, what am I reflecting, what am I summarizing, what do I put into those things? And you have a reason for reflecting certain things more than others, for asking certain things more than others.
So what were some of the reasons, or what are some of the rationales behind which statements you choose to reflect?
Well, what you're always thinking one step ahead in motivational interviewing, at least when you're evoking.
Okay.
Because if I say this, what is the client likely to say next? So imagine a smoker saying, you know, I know I really ought to quit, but I really don't want to. I mean, I enjoy smoking, and I think, in fact, I'm not sure I could even do it. Now, what could you reflect there? You could reflect, you're not sure even if you try, you'll be successful. What will the client say next? Well, they'll talk more about their thought that they probably can't do it. Or you could reflect, you really love smoking. This is something that's very important to you. What will the client say next? They will tell you what they love about smoking more. Or you could reflect, at the same time, you know that you really ought to quit. And what they're likely to say next is something about why they
smoking
are thinking
is
that.
helpful.
And so it's that, and you don't have to think 12 steps ahead. It's even better not to. Just thinking one step ahead, but something that you think will be followed by change talk. There's very good process research now that MI questions and MI reflections are much more likely to yield more change talk than just random questions or even the opposite kind of question. So you get more of what you ask for, you get more of what you reflect, you get more of what you affirm, you get more of what you emphasize in summaries. And so there's strategic reasons to just shine a light on, emphasize particular things in what the client is saying.
So Rogers was much different in the sense that he didn't care at all about sort of moving the client forward. He cared predominantly or only about allowing the client to feel understood and heard.
I think he cared deeply about helping the client to move forward.
But I mean, in his strategy, that's not what he was looking to. Yeah.
Yeah.
Of course, he was wanted to help the client, but yeah.
Yes, that's right. Now Charles Truax, one of his students, did an analysis of Rogers' own counseling and published an interesting article saying Rogers is not responding randomly. He's not responding non-contingently. It's certain kind of material that he's more likely to kind of light up and sit up and take notice and reflect. And other things he's much more likely to kind of let go by. And it's the things you would guess that positive material, that clients' sense of prizing themselves or self-esteem and so forth, and those he's more likely to pay attention to. So Truax is saying Rogers is actually not non-directive, or at least not non-contingent. And if you think about it being truly non-contingent in what you reflect would be bizarre. Everybody has some reason for choosing to reflect certain things and not others. But Rogers never verbalized that or never talked about it that much. But I think his clear heart was in helping people to move forward toward their own best potential. And got some evidence from his own research that what he was doing does that.
Yeah, and Rogers was also very comfortable to sit in the problem with the client. I see in the motivational interviewing, it's more, what is the word? Results-based or more, I can't think of the word now, but it's more, you're more results-based, looking to get to the end.
Well, we have a focus, certainly. And once we have a focus, we're much more asking about, talking about, reflecting, summarizing on that. So when people who know Rogers watch me work, they say, well, you're much more active than he was.
Yes.
You reflect more often than Rogers did. So there's some differences in what I do from what Rogers was doing. There even been head-to-head comparisons of client-centered therapy and motivational interviewing, with finding more movement, more momentum with a conscious motivational interviewing where you're trying to move in a particular direction. Usually the reason why you're doing that is that's what the client asked you to do. But we've learned a lot about how to help people talk themselves into making a change.
Let's take a question from Naomi. Naomi, go ahead. Thanks for joining.
Hi, thanks. I guess when I think of motivational interviewing, I guess it really applies to any self-sabotaging kind of behavior. But where I'm wondering about how to use it is particularly in regards to either a couple or parents, not necessarily in the context of a couple, when they really need to make some changes for the benefit of their child. And what could you say about that very big topic?
Mhm. Well, actually, there's been a fair amount of application of that. Interestingly, the two areas I think where I think there's been most use of motivational interviewing with parents for the benefit of children is around stopping smoking, or at least reducing children's exposure to secondhand smoke, and preventive dentistry, of taking care of children's teeth while they're young, so that they have healthy teeth when they're adults. Seems to work pretty well. If nothing else, I think motivational interviewing has taught me what not to do as a parent, what's likely to be self-defeating behavior, which is telling the kids what they have to do and why they should do it and so forth. There are times when you do that. You let your child run out in the street. You say, you grab them and stop them. But as kids get older and have more self-determination, they're much more involved in the process of deciding what they will be doing. If you take the authoritarian approach as a parent, you're likely to evoke the opposite from them, which is why I think you see better outcomes with the middle ground between very permissive parenting and very authoritarian parenting. It's that kind of that dance of guidance when needed, but also stepping back and listening well and respecting the child's feelings and autonomy.
So you're saying you would emphasize that to the parents as a therapist?
Yeah, I would. Well, first of all, I would be doing motivational interviewing with the parents around making the changes they need to make. But then I might also be teaching them what to do and what not to do in talking with their own children. That's likely to lead in a positive direction.
Thank you.
Okay, thank you for that question. So Bill, let's talk about, essentially what MI is doing is it's working with resistance.
Working with ambivalence.
With ambivalence.
We stopped using the term resistance, or at least we tried to reframe it in the third edition. Because resistance kind of sounds like you're blaming the person for what they're doing, either their pathology or they're just being difficult or whatever. Right. But it takes two people to resist. Nobody sits in a room and resists alone. So it is a dance between two people, and that means I have a role in it too. And I can teach you how to have very resistant clients, and I can teach you how to have very low resistance clients, because it has so much to do with your communication style, with the way in which you interact.
Okay. How do we address the overtly resistant client, the one who is let's say the one who's mandated to treatment?
That was my normal client, of course.
Yes.
In addiction treatment. More than half of people usually are being pushed through the door by somebody.
Yes.
Maybe the courts, maybe the family, whatever, but someone else has urged them to be there, which is good because they're coming in earlier than they would have come in just on their own judgment. Actually, it's one of my favorite kind of people to work with, because someone who's got that kind of defensiveness and fight in them, there's a lot of energy to mobilize there. And it's not that difficult to do. You certainly acknowledge the person's not wanting to be there or unhappy with it or whatever. But pretty soon, you can form a working relationship and it begins moving in a positive direction. And if you watch this in expert tapes of motivational interviewing, it happens within minutes even. There was one guy who was sent to me to talk about his drinking. He didn't want to be there, didn't want to talk about it. And his opening line was, "I think smoking is my real problem." And I said, "So drinking really hasn't caused any problems for you?" And he said, "Well, no, anybody drinks as much as I do is going to have some problem with it." And I listened some more to him for a while, and I don't know, 3-4 minutes in, he says, "You really don't know anything about me, do you?" I said, "No, I asked not to be told much about you. I just wanted to meet you." And he said, well, let me tell you my story." He literally leans forward. And from that moment, I'm no longer the enemy. Before that, he was talking about addiction counselors and the way his resentment about what had happened to him in the past. And I was one of them, And after that moment, I'm no longer one of them. Now we together occasionally talk about addiction counselors, but I'm not part of that stimulus class anymore.
Mhm.
And it happened relatively quickly. So people used to come to motivational living training asking, "How can I deal with the most difficult, impossible clients?" And they would want to role play the most difficult, impossible clients, who actually are more difficult than their clients really are. What we've learned now is when you learn the rest of motivational interviewing, you don't actually get that much resistance or defensiveness or discord. It just kind of brings that down to begin with. And when it does arise, you're using the very same kinds of tools to deal with it and diffuse it. And it works very well. It's a de-escalation method
De-escalation.
that police
Right.
officers learn. Yeah.
Bill, you shared a little surprise with me when we first spoke right before the show, because I had asked you a question about what makes therapy work.
Oh, yes.
And you told me that you actually just published a book within the past year called Effective Psychotherapists. Here it is, for those of you who want to see.
You
Interesting.
found it, yeah.
It's not called Effective Psychotherapy. It's called Effective Psychotherapists.
Yes, that's right. That's right.
And I'm sure there was thought put into that name as well. And so can
Well,
you tell us, what is
yeah.
the book? What is the book about?
Well, there's this interesting phenomenon in psychotherapy right now that if you compare two bona fide psychotherapies head to head with each other, done by people who are trained in them and believe in them and are expert in them, you usually don't find significantly different outcomes. One of the most spectacular demonstrations of that for us was a program called Project Match, where we had more than 1,700 clients. And we were testing 3 different treatments that we thought would be just as different as they could be for people with alcohol problems. Cognitive behavior therapy, 12-step facilitation therapy, where you're trying to get the person engaged in and understanding the 12 steps in AA, and motivational interviewing. And people were randomly assigned to those 3 treatments. Mm-hmm. They finished dead even, much to the surprise of many of the principal investigators, most of whom were cognitive behavior therapists. But the overall improvement was the same, and what's pretty good, for all 3 treatments. Within each treatment, there were big differences in outcome depending on who the therapist was. Now, we've seen that over and over again, that actually who was the therapist accounts for more variance in outcome than what the treatment was. So I got interested in what is that about? What is it about therapists across schools of psychotherapy who generally tend to have clients who do better as compared to ordinary outcomes, or even therapists whose clients on average do worse because they exist also. And so we read 70 years of psychotherapy research. Took a couple of years doing this to try to identify what are the characteristics empirically demonstrated associated with better client outcomes. And they're things that therapists do. This is not magic or mystical stuff, but they are characteristics of the therapist. Now, the biggest one is accurate empathy, well described by Carl Rogers in the 50s. The ability to listen to and understand what your client is telling you and to reflect that understanding back to them. Therapists who are high with that skill tend to have better client outcomes in all sorts of therapies, in all sorts of problem areas. And it turns out therapists who are low in accurate empathy tend to produce outcomes worse than no treatment. You're better off being on a waiting list or going home with a self-help book than working with one of those therapists. So accurate empathy has one of the biggest effect sizes, but we found 7 more.
Okay, can we stop before number 2?
Sure.
Can you tell me, why do you think it is that accurate empathy engenders change?
Boy, there's a great question. I don't know that Rogers ever really explained it. I mean, I get a complex theory of change in personality. I accept that it is so, and I certainly experienced that it is so in my own work.
Mhm.
But explaining why, listening well to people helps them to change.
Mhm.
I'm not sure. Now, one of Rogers' ideas was that when people feel unacceptable,
Yes.
they're paralyzed.
Yes.
It's very difficult to change when you experience yourself as being unacceptable. And that when people experience acceptance as they are, it becomes possible to change.
Yes.
And an interesting paradox right there.
Yes. He
Well,
said the paradox of human change, right?
Yeah,
Wasn't
that's
that
right.
his- Yeah.
That's right. And one thing you're doing with accurate empathy is accepting the person
Yes.
as they are and working hard to understand them.
This has always been my hypothesis, that in as much as the therapist can demonstrate that the client's experience is relatable, so
Mhm.
that means that the client is acceptable in their experience, and the shame or ambivalence that they have surrounding that experience is resolved, and now
Yes.
they can move forward because they can just be as they are.
That makes
Beautiful.
sense to me.
Yeah.
I don't think empirically we can show that that's the reason, but the finding is there.
Mhm.
And
And
it
I
makes-
think that's the significance of the accuracy and the empathy. The closer
Yes.
you get to touching the client's experience, the more acceptable and relatable and understandable you're making them.
And it's not about you having had the same experience.
You don't have
It's
to
not
have
about
some-
you experiencing at the same moment what the client is experiencing. That may happen. But that's not what it is. It is the ability to understand and reflect back to the person their own experience. That's the key that is related to better client outcomes and has been for 50 years.
Okay, what are some of the others?
Well, number 2 is acceptance, actually, because that's a separately measurable component of directly communicating to clients your acceptance of them. Affirming strengths, for example, is a direct version of that. It's almost the opposite of non-acceptance. It's the absence of judgment, the absence of blame and shame and criticism and all of that. So those things not there, not judgmental.
Would you include in acceptance? Would you include the acceptance of the client's inability to accept themselves, or struggle to accept themselves? In
Sure,
other words,
that's what-
we're not just accepting the client for who they are, superficially, but also for the challenges and struggles that they're experiencing as well.
Of course, and then wanting to communicate those clearly in your understanding of them back.
Yes.
So
Yes.
these are not separate things either.
That's right.
They fit together. The third is the third of Rogers' 3 conditions, and that's positive regard, of communicating your respect for and regard for and prizing of your clients, and doing that actively and intentionally.
I struggle with that, because I think that if you have numbers 1 and 2, then by default, number 3 is applied.
They fit together. They
Okay.
do.
Because
And
if you're that invested in understanding the patient's experience, you must be prizing them in that way.
Makes sense to me. Yeah. And its effect size in itself, it's smaller than empathy is. But it does seem to have some independent contribution, which is interesting. So really, this book was about trying to understand what's going on with you. What are you actually doing? And each of these 8 we talk about as an internal experience, an experiential component for the therapist of what's going on in you when this is happening.
Right.
And then an external behavioral manifestation of it. how are you communicating that to the client? Because if you're just sitting there feeling positive regard for the client, it doesn't probably do the client much good unless you're also communicating that. If you're sitting there feeling accurate understanding of the client, but not communicating it, it's not doing them that much good.
Right.
So
I like
both
to
things
say,
are there.
I like to say that the best moments in therapy are when the client says, exactly.
Oh yeah,
That's
those are
kind
great.
of like when you nailed it and they feel connected right there.
Yes, yeah. One example I used in one of these books was a fellow I was counseling who was a symphonic musician who was depressed also and came in talking about his loneliness, how empty his life felt. And I at one point offered a reflection, and I said, it's like the sound of a flute in an empty concert hall. And he said, yes, and broke into tears. I mean, those, when you can find one of those that in the person's own image system touches what they're communicating, it's very powerful.
Okay, so we got positive regard.
Positive regard, acceptance,
We
and
got
accurate
acceptance.
empathy.
Yeah.
Genuineness. This is being yourself, not putting on a mask, not trying to be a distant expert, whatever, but being yourself. Sharing something of yourself when there's a good reason to believe that will be beneficial to the client. And again, not being dishonest. Not saying that you're not feeling something when you are, for example.
Especially when it's a negative feeling. And
whatever, yeah.
even positive
Sure.
feelings. Yeah. And Rogers made it his business to share his positive feelings towards his clients as well.
Yes, indeed. Yeah, yeah. So then that's a separately measurable. It's the most difficult of the 8 to measure, genuineness. But nonetheless, it shows positive relationships to client outcome. Then we put focus, which is what I was talking about. Therapists who kind of know where they're going and have a clear plan for getting there and mostly stick to that plan tend to have better outcomes than those who just talk about whatever the person brings in that particular week. And there's not a momentum to it. So that's another one that has a direct effect. Hope. Now we think of that as a client variable. That clients who are hopeful are more likely to get better, and it's true. But therapists' expectations also are self-fulfilling prophecies, and there's lovely, interesting research.
Interesting point. Yeah.
That if you expect your clients to get better, they're more likely to do so. If you get cynical and think this client's not going anywhere, they likely will fulfill that for you too. One example that I use of that is the concept of a waiting list. And I used to use that in clinical trials, thinking it was an ethical control condition because everybody eventually gets the treatment, right? So that's fair. But it turned out people on the waiting list changed not at all, absolutely flat. Whereas clients that we give a self-help book, or you say, I'll see you in 10 weeks, but here are some things you can do in the meantime, showed dramatic change, often the same amount of change as if they've been seeing a therapist.
How's that?
And why is it? Because clients on a waiting list are doing what we told them to do. They're waiting. The implicit communication is you're not expected to get better until I can treat you.
Fascinating.
Unfortunately, I can't treat you right now, but when I treat you later, then you'll be okay to get better. And our clients are very kind to us and fulfill that expectation. They don't change at all while they're on a waiting list. Then when they come in, then they show not as much change as those we treated immediately, by the way.
So, wow. So in other words, you're demonstrating hope by providing the client with some content that can help them grow. You're saying, look, I know you can grow while you're waiting. Go take care of your problem.
Here's something you can do. That's right. Yeah.
That's great.
Yeah. So that waiting list is a good example of that. We put evocation on the list. Evocation is a kind of strategic directional way of trying to, in your psychotherapy, evoke certain kinds of experience or language from your clients. In person-centered therapy, it gets called experiencing. And so clients who show higher levels of experiencing, which is talking about yourself in present tense, in immediate language, not in the abstract, not in the past, but here's what I'm experiencing now. Here's what I'm feeling right now. That present tense active experiencing is associated in client-centered counseling with better outcomes. And it turns out that experiencing is related to the three things that Rogers talked about as key components of effective psychotherapy. So what you do as a therapist determines the extent to which the client is showing experiencing, and that in turn predicts better outcomes or worse outcomes. In motivational interviewing, it's the balance of change talk and sustained talk. So we're consciously listening to the client's own language and trying to find their own motivations for change and have them verbalize them, have them say them. And we have good research that matters. That clients showing more change talk than sustained talk tend to have better outcomes. That wouldn't be surprising in itself. You'd say, well, yeah, motivated clients get better. Except that that balance is very much under the control, experimental control of the therapist. So we can drive those two up and down independently by what we're doing in counseling. So evoking is looking to call forth during treatment sessions something that's associated with better outcomes. That is something the client is doing in the session. And then the last one is offering information and advice. Sometimes that is sufficient. Sometimes the doctor's saying, I really strongly advise you to quit smoking, in the interest of your health. 2-3% of the time, people will do it. And so, advice can have
So
a positive impact.
psychoeducation is part of an effective therapist.
Yes, but it's how you do it.
It's with
And
using
then
all the
also-
other steps.
That's right. You do it through using the other skills.
So Bill, I mean, here's the $1 million question, and not to disturb the marketing of all the modalities. Is it fair to say, this is an argument that I've been making all along, this is actually why I started this whole show, but is it fair to say that if we put aside all of the modalities that are coming out or that have come out over the course of time and focus on training therapists how to be therapists, how to utilize their selves, utilize the listening skills, polish up some of those reflections, that we can put aside pretty much all modalities and just treat the person to person.
Well, that is a kind of client-centered or person-centered way of being. And what was most emphasized in Roger's own work and that of his students was these attributes of therapists that are associated with better outcomes. I think this should be taught in clinical training programs. And I think it should be the first thing we teach in clinical training programs. I was fortunate to have that experience. There was a year-long course at the University of Oregon where I got my doctorate in how to talk to clients. And it was an extremely behavioral program. And none of the behaviorists wanted to teach that course. So they went over to the education college, got an academic grandchild of Carl Rogers to come over and taught us that course before we ever did any behavior therapy.
That's great.
It made all the difference in the world for me. And I think many programs just don't pay enough attention to these how you do treatment things.
Yes.
And are much more focused on techniques.
Yes.
Do this technique. Do this
Rollo May called them gimmicks.
Gimmicks, yeah. I mean, you don't have to be that cynical about it. I think it's a both. I think it's a both and. I mean, I don't believe that it's irrelevant what you do in the treatment room. I mean, I think there are some forms of treatment that are better than other kinds. They're harder to find. And also clearly,
you cited the studies that show that it really had to do with the therapist, the characteristics of the therapist, not the modality.
That's true too. Yeah. So what I've been saying is it matters what you do and it matters how you do it. And the how you do it is the therapist skills that we've been talking about. When we finished that book, I realized, in a way, this is what we've been doing with motivational interviewing for 40 years. We've kind of been teaching these therapeutic skills because at least 7 of those 8 are clearly embedded in motivational interviewing. And the 8th, genuineness, just because we've ignored it, we haven't said that much about, but we're going to in the 4th edition. But in a way, motivational interviewing operationalizes how to do this. I mean, how to be with people, which is one reason I think it crosses professions and schools of psychotherapy and cultures so well.
Because it's a form of communication that really helps people to feel connected with each other.
It's a way of being. When I found Carl Rogers' last book, which is called The Way of Being, I literally wept, because this is how I understand what we're teaching also. We're teaching therapists a way of being with people, whatever they do, whether it's diabetes education or preventive dentistry or whatever it is. It's a way of being with people to help them move in a positive direction.
Yeah. I want to give a special shout out to Aaron Herzog, who's on the call. You can see him. His video is on. He's one of the gracious people who lets us actually see his face. Aaron, thank you for connecting us with Bill Miller. And somehow Aaron has this knack of finding email addresses and contacts, of people who nobody else can seem to get a hold of. So thank you, Aaron. Does anybody else want to share a comment or ask a question? Now's your chance. Motivational interviewing, or on therapy, or effective therapists, psychotherapists. Okay, Esty, I see you have a question. Can you raise your hand, or actually you could just unmute? And if you
sorry.
Okay, sure.
So something that I'm really struggling with is that I just feel like there's so many people struggling so deeply, and I personally work with, sex addicts in specific, so that's kind of a whole nother thing, but they've been through so much trauma and so much pain, etc., that is so in my mind, it's like unfathomable how these people can get through and over such atrocities. And I find myself, I'm maybe ashamed to say it, but I find myself sometimes thinking to myself, like, how is this person going to get out? Like, as much as I can be there for them and give them, unconditional positive regard and all that stuff. I guess I'm thinking about, like, just the belief aspect. How do you continue to believe day after day when you just see somebody falling and falling and falling, going to rehab 10 times and not making a difference? I don't know. I guess I'm kind of wondering, like, how can I regain that belief that, no, maybe they really could change? Or maybe it's, I don't know, maybe it's a matter of just my I don't know, maybe the ideas of my expectations, maybe my expectations have to change. I tend to be more on the side of cautious, and I think to myself, I mean, even the smallest change to me is huge, and I like to point that out. I won't lie that kind of behind closed doors, that's kind of what goes through my mind sometimes with some clients, is like, how do you keep having hope and belief and faith?
I had a real advantage there in that I spent a lot of my career doing outcome research. That is, trying to find everybody we treated a year later, 2 years later, and see how they're doing. And we kept in touch with them along the way. So usually 3, 6, 12, 18, 24 months maybe, we would get back in touch and interview them and just see how are you doing, what's going on, in a very structured way. When you do that, what you see is how well most people are doing. What you see is all the positive outcomes that you don't see if you're not getting in touch with people. Instead, what you see are people coming back and struggling and having difficulty, which can give you this kind of jaded perspective that, we're really not being all that effective. So that was a boon for me, that just to try to talk to everybody that we had seen and see how much change had happened and had continued and grown even over time. Wow. The outcomes, one of the reasons I've stayed in addiction treatment for 50 years is the outcomes are so good.
Really?
Now that runs contrary to public opinion,
Sure.
Even runs contrary to professional opinion, but I would put them up against the outcomes for any other chronic illness. I mean, the percentage of people who, first of all, get completely clear, that is in total remission, is pretty high. And then if you take them out of the picture, we did that in one huge study, So let's remove all the people who have abstained completely from drinking. So now they're out. What's happened to the rest of the people? Their drinking was down by 87%. And they were healthier and their life problems were significantly better. And those are the failures from a perfectionistic way of thinking. We've suffered in the addiction field from being perfectionistic, that either you're 100% abstinent or you're a failure. Well, it doesn't look like that when you do outcome research. Most people are way better off. There are some who are not doing well, of course, but most people are doing fairly well. and that's definitely in alcohol, tobacco, marijuana. I mean, those areas, the outcomes are really clear. We're dealing with tougher drugs now. For some of them, it seems, particularly the opiates, it seems like maintenance on a more benevolent opiate is the best thing we have to offer most people. But good outcomes are there. And I would say try to find a way to see those. Maybe do a routine follow-up with people that you've treated, see how they're doing. You know, it's good for you in addition to it being a good thing for patients. They perceive it as continuing care. At 2-year follow-up, we asked our clients to tell us about their therapist. And they often describe the research interviewer who had been following them over time, ever since treatment. And they perceived that person to be a helpful therapeutic change agent for them, even though her job was to collect data and just kind of document how they were doing. They loved her. And saw her as someone who really cared about them and kept in touch with them, stayed with them over time. It's primary care. We've done, in addiction in particular, we've done too much specialist care where treatment has a beginning and an ending. You even graduate from it, which is a strange idea. And if you look at it from a chronic disease management perspective, it makes a lot more sense for addiction. It's about staying in touch over time and stepping back and intervening as needed, which is what you do with hypertension and diabetes and other kinds of chronic medical conditions as well.
Interesting. Cool. So you feel like you're saying that if we were able to, because I feel like I guess it depends, who you're working through.
Of course.
Yeah. So I guess I'm just thinking about one client in specific that it's interesting because I had a client that I was working with that like you said, I was able to follow up with them a few months after, not so much after that.
Yeah.
And then that there was, there was really a lot of gain from the work we did together. But that's really interesting, is to really look at, there's so much more to it than just, sober or not sober.
And a few months is good, by the way. I mean, outcomes 3 to 6 months after treatment ends are pretty predictive of longer term outcomes. So, and that's definitely true in addictions, that it's not that then everybody falls off the wagon and gets worse after that. The outcomes at 3 to 6 months are pretty good predictors of longer term outcomes. Not for every individual, but for the group as a whole, to give you a good sense of it. So maybe that's something that you could do, just kind of get in touch with people after they've been out for a while. See how are you doing? That's good continuing care anyhow. Some insurance plans even allow reimbursement for that as continuing care.
Really? Okay, thank you so much.
You're welcome.
Okay. Well, Bill, I appreciate that you agreed to come on, give us of your time to, help the mental health community. This email is going to go out to, the recording's going to go out to around 900 mental health professionals who I'm sure many will take a look at it, especially on the topic of motivational interviewing. So thank you very much for joining us and gracing us with your presence and knowledge, and for this surprise about effective therapists that we got to hear this other piece besides motivational interviewing.
You're most welcome. I mean, I love talking about the work that we've done because we make knowledge for export.
Well, thank you.
Just keep in journals.
Thank you. And we're going to call it a night. Thank you, everybody. We hope to see you again next week. If anybody would like to say hi after the show, please, by all means, stay on. And I'd love to meet you. Okay. Good night. See you next week. Bye-bye.
Bye.